Good morning, everyone. I would like to thank all the people on the dais, especially Dr. Arup and Dr. Sai, for giving me this opportunity. I'm going to do a very basic talk on someone who's learning how to convert from SICS to Phaco. What are the things that you can do? Now, for all of us in the medical field, the first thing when you're trying to do something new is to try and look at the literature. Now, if you go to PubMed or even in Google and try and study about transitioning from Phaco to SICS, you will find hardly any literature because all the literature is in the West and they talk about transitioning from Phaco to SICS, not SICS to Phaco. So for us in India, we who learn SICS first and you want to start doing Phaco, the first thing that you need to do is to go for wet lab training. There is no substitute to this. You can't straight away start on a human eye before doing wet lab training. Of course, make sure you're comfortable with your microscope, especially depth perception. Do not try and learn Phaco if you're not yet fully comfortable with SICS. Rexus size is important, especially doing a Rexus. Make sure that you're already doing a Rexus all the time. And in Phaco, usually the Rexus may be slightly smaller, so just keep that in mind. Now, this is a very important step that I suggest to all my juniors, and that is to get comfortable with the Phaco foot pedal. Try and do bimanual IA. You can make 2 small side ports on either side and do the IA through that. Now, that is just to get used to the Phaco foot pedal. Remember, there's a difference here. You have only 2 positions, that is irrigation and irrigation aspiration. You don't have 3 positions like you have when you're doing Phaco proper. Learn to implant foldable lenses. You can make a 2.8 millimeter side port incision and try and put foldable lenses through that to get the feel of how it will be when you're doing a Phaco emulsification. Using your non-dominant hand is very important. Try and do some writing, brushing teeth. Use your left hand when you're doing SICS surgery more. Try and do a Rexus with your left hand while doing SICS surgery. It's very interesting. It is such a positive reinforcement when you complete a Rexus with your left hand. You feel that you can start doing things better. Learning about the machine is important. Remember that you have to know about the parameters, what is being used. Preferably have someone from the company. They will give you and help you with your settings in the beginning. They can help you. You cannot use the settings of a senior surgeon when you start. Learn a bit about the Phaco tip, especially what kind of tip you want to use. It's slightly different, especially some of the Kelman tips which are angulated quite a bit. You might end up in trouble because you're not used to that. So learn a bit about it and be conscious of that when you're starting surgery. Get additional instruments. Don't try and minimize just managing with your SICS instruments. Whatever new that you need, please buy that. Learn how to use sharp instruments, especially inserting it in the eye without damaging the wound. This is totally different from an SICS wound which is wide open. You must learn how to get in and out without damaging the eye. Then you move to using coaxial IA. Again, if you have a 2.8 coaxial IA, make a 2.8 side port. After removing the nucleus through SICS, do your IA through the side port and learn how to use the coaxial IA. Now, what we always recommend for all PGs is to do the step-by-step training program where you don't do the whole surgery in one go. You do a step-by-step. First thing is to watch videos, watch plenty of videos, assist a lot of cases. This is not given enough importance now. You must scrub up and assist the senior surgeon, learn how they assess problems. They will tell you how to recognize early signs and how to manage the complications. A wet lab structured program, there are so many places that organize that. This is what we do in our places where we train. We first start with IOL implantation, then making the corneal incision, then learning how to do IA, cortex removal, then doing capsular access, nucleus fragmentation after the initial crack is done, then trenching, then breaking the nucleus, and finally the whole surgery. Knowing how to do anterior vitrectomy is paramount. Please do an automated anterior vitrectomy for your complicated SICS cases. You can't start doing it in your Phaco cases. You must learn how to do it in your other SICS cases. Choose cases carefully. Don't go for the difficult deep-seated eyes, one-eyed patients, hazy corneas. This, of course, be very careful. Now, even if you're comfortable with topical anesthesia, please give blocks when you're learning a new surgery and decide on the technique you want to do. When to convert, this is to convert, when you're doing Phaco and you run into trouble, these are some of the parameters that I would look at. If you're running into any difficulty, convert back to a technique that you're comfortable with. It's more important to give the patient good vision than to say that we did the surgery in a difficult condition. I'm just going to end with one small video. For those of you who are working in settings where you don't have a senior surgeon along with you, this is how I learned 20 years ago. So I was comfortable with SICS, so I would make a temporal incision and try and do a temporal Phaco sitting at 12 o'clock. And now the reason is if I run into any trouble, I can convert to a superior SICS. Now here you can see that a trap flap has been made. It's a combined surgery, but I just took it to show my technique for Phaco emulsification. So at any point of time during the surgery, because I'm alone and I run into trouble and I want to convert back to an SICS, I can use the superior wound to convert back. Here now there is a slight difference that I do here, and you would see that my side port is almost 180 degrees away from the main port. That's because I use a supracapsular technique nowadays most of the time. This is to cut down the energy use, where you go on top with the Phaco tip and you go below the nucleus with your left hand. And so there is no initial trenching, but that's not part of this study, this talk. I'm not going to go into the details. Just learn how to, if you do this, if you run into trouble, you can't crack the nucleus, you can't do something else, just stop and convert to a superior SICS, what you're comfortable with, so that you can finish the surgery. The end of the day, remember that you can do a new surgery, but you have to work hard at it. Don't give up hope if you have a few troubles. All of us have gone through the same part. Thank you very much for your patient listening.
Thanks a lot, Dr. Jacob. It was a beautiful presentation.